Hello, my name is Brian Flynn. I'm one of the EMS educators for Regions External Education. I'm helping out Mel Jorgensen today. We're going to be talking about trauma triage. It's important that we go ahead and separate trauma triage from MCI triage. MCI triage is kind of what you guys are used to. So is the patient a green, yellow, red, or black? Trauma triage, on the other hand, looks at a singular patient and says, is this patient a major trauma patient that needs a level 1, level 2 center, or are they a minimal trauma patient who could deal with a level 3 or level 4? And then it has a specific way to go through and assess all of your trauma patients, which we'll put a little bit of emphasis on. And then we'll go through a couple of scenarios with emphasis on assessment, treatment, transport plan, just so we're all on the same page for that. These are just the objectives that we're going to go over. We're going to identify triage criteria. We're going to state the 4 steps of field triage decision scheme, and then examine our local protocol. So step 1 of the 4 steps we're going to go through, we're going to assess the vital signs and level of consciousness. It's the same thing you do on every patient contact, right? Hello, my name is Brian. I'm a paramedic. I'm here to take care of you today. How can I help? And if the patient responds with, "Hi, Brian," then I think they're doing okay. If they don't respond to that, then I start assessing for level of consciousness. So are they alert only to verbal responses, painful responses, completely unresponses, or hopefully alert oriented, and then I can actually get some questions answered. Then you're going to assess patients' vital signs. For a trauma patient, the things I want you to focus on are, is the airway open and patent? Are they breathing at a regular or irregular rate? And are they having any labored breathing, or is it easy for the patient to move air? And then I'll assess for peripheral pulses. And when I assess for the pulse, I want to know, is it present? Is it strong or weak? Is it fast or slow? Is it regular or irregular? If I can get all that info, I'm pretty darn happy. The NCCR also suggests that you guys should get a blood pressure. I can tell you I do not get a blood pressure on scene on every single trauma patient, especially if it's a major trauma patient. You should get a blood pressure early in patient care, but it's not necessarily the thing I'm going to do while sitting outside in the snow. Step 2 is we're going to start looking for, where did the injury occur? How bad is it? Is it a head injury, a truncal injury, or an extremity injury? Or is it a combination of all of those 3? What you see on this slide is your GCS score. Most of us with our charting material will just enter in their responses and it'll pop out a number. But this is more for you guys to keep in mind. So I'm looking for their eye responses, their verbal responses, and their motor responses. Step 3, we're going to assess for mechanism of injury, evidence of high energy impact. A couple things to keep in mind. Vehicles are now made specifically to take a large impact and prevent that force, I guess, from getting to your patient. So we are not there to assess the injury to the vehicle. We should be assessing the injury to the patient. So I'm sure you guys have all seen this, right? 60 mile per hour MVC, patient was belted, seat belts were airbags were deployed. Patient is out walking around saying my knee hurts. On the other hand, I'm sure you guys have seen patients that were driving 20 miles an hour, but no seatbelt worn, no airbag deployed, and they're barely responsive at that point. So while the mechanism is important, it is not the only thing to base your assessments on, but we should look at how much force could have been applied to the patient, because that might guide us in how we do our assessments. Step 4, special populations. NCCR considers elderly patients to be anyone of the age of 55 or up. And keep in mind, elderly patients, even for a fall from a standing position, can be considered dangerous depending on the patient's underlying medical conditions. Children are always going to be considered a special population. One, because because they compensate so darn well right up until they don't, and then they decompensate rapidly. The second reason that children are going to be a special population is because they're not always capable of telling us what's wrong, which just necessitates that we have to be really good at doing an assessment because the patient won't be able to give us necessarily answers for the information we're looking for. Any patient that's on an anticoagulant or has a bleeding disorder. So if my patient's on Coumadin or Plavix, they're at a higher risk of internal bleeding and not being able to stop that bleeding. If my patient has a bleeding disorder such as hemophilia or von Willebrand syndrome or disease, we have the same concerns, difficulty with clotting. Any patient with burns, I want to consider a burn center, but we'll also have to base that on the depth of the burn and how much of the patient was burned. Any patient that has a pregnancy and gestation greater than 20 weeks, we should consider a trauma center, mainly because the hospital has to take care of 2 patients, not just 1 patient now. And then anytime that you as the provider are concerned that there's something else going on that we don't necessarily see, bring it to a trauma center. Call it as you see it and let the hospital work with it when they do their more thorough exams that they're capable of doing. So let's go through a couple of scenarios and just kind of put this into action. So right here you have this male patient, we'll call him, let's say mid-40s, struck by a pickup truck while crossing the street. Front end damage to the truck. Patient is only responsive to pain with moaning. That's all we got. You see the injuries that you currently have. So as you start doing your ABC assessment, airways open and manageable. Breathing is labored, roughly 10 a minute. Circulation, will say a peripheral pulse is strong at 72. Skin is cool to the touch. For those of you that check a BP on scene for this guy, we'll call it 110/64. The GCS score that's up right now, so you see the little chart on your screen, we'll say that his eyes open in response to pain. When you assess verbal response, he has incomprehensible moaning noises, and he's able to localize pain when you assess for it. So as far as that motor response is concerned, I check this maybe differently than some other people. When I walk up to a patient, I'll say, "Hi, my name is Brian. I'm a paramedic. I'm here to take care of you today," and I'll extend my hand to go ahead and shake theirs. If they're either incapable of shaking my hand or don't recognize what a handshake is for, that patient is below a 6 on the motor response. Localizing pain means that if I did a pain response to the right hand, they specifically pull their right hand away from me. Withdrawal from pain would be if I provide pain to that right hand and they kind of turn their entire right side of the body away from me. The brain is recognizing that pain is occurring, it's coming from that right side, but they can't localize specifically where on the body that pain is coming from. So this patient, opens eyes to pain is a 2, verbal response incomprehensible is a 2, withdrawal from pain is a 4. So patient has a total GCS of 8. So what do you want to do with this patient? The suggestion would be full C-spine precautions, right? Patient still lying on the ground. Patient was hit specifically by a pickup truck. Very concerning. We'll say the patient has an unstable pelvis and potential fractures to the arm. So C-spine, backboard, universal splint is great. I'd also consider just rolling this patient when they go onto the backboard. Have your pelvic splint already on the board in the correct spot. So when you lay the patient onto it, you just go ahead and pull that pelvic strap down too and keep that in place. It also kind of helps with keeping blood pressure up and preventing blood loss, which is amazing. For this patient, you'd probably want to consider going to a level 1 trauma center if that's available. Level 2, if a level 1 is more than a half hour away, you can do a level 2 trauma center if that would be within 30 minutes. Just keep in mind this would be a TTA activation due to the lower GCS and the high potential for internal injuries. Something else I would want you guys to consider. So we have a patient that was struck by a pickup truck. Blood pressure 110/62, pulse in the 70s. Those vitals sound great for a patient that I found sitting in his or her living room. For a patient that was just struck by a truck, I really expect blood pressure, pulse, or both to be quite elevated. And the fact that neither of them are leads me to one of 2 issues. Either the patient is taking some kind of medication that is preventing him or her from compensating. So I have a patient on metoprolol or labetalol, any of those LOL medications, that'll prevent the patient's blood pressure and heart rate from increasing. So that means the patient can't adequately compensate for blood loss. If the patient's not on any of those meds and still has the vitals as presented, I might be concerned that they're already decompensating and be a little more aggressive with my treatment plan. So consideration of starting an IV or two early, hanging a bag at TKO, and prepping for the inevitable drop in pressures, just so you're ahead of the game. And if it never happens, all the better, because it's better for your patient that way. But at least you guys were prepared in case things were going to go awry. Next patient. You guys get called for what do we call him, a 57-year-old. You find him sitting in his recliner. He fell out of the pickup truck you see on the left side there. He had just gotten home. Patient had knee surgery about 4 to 6 weeks ago. Sorry, I had to cough. I turned off the mic for a second. Had knee surgery about 4 to 6 weeks ago. We'll say a wife and his child had to help him off the ground, helped him over to the chair. And while we couldn't find specifically a picture of this, let's say that the patient has some minor bleeding coming out of that pant leg. So, as we start our initial assessment, one of your partners goes ahead and cuts off that pant leg, and you start doing your vitals and AVPU. So, patient's awake, alert, oriented. Airway is open and manageable, is breathing 16 times a minute, he has a pulse of 92. In the peripheral, strong. Blood pressure 168 over 98. You note that he's a little bit warm to the touch, and you get a temperature of 100.5. The leg on the side there is this patient's leg. This comes from a real patient who had had a recent knee surgery, just like the patient in this scenario, who had a trip and fall, and the surgical scar ripped open because it hadn't fully healed and it tore open most of the leg. That bulbous area you see in the middle is actually the patient's kneecap. This was continuously bleeding as you guys arrived on scene. You could find no specific blood vessel to attempt to put pressure onto, such as wound packing. So let's just say you guys placed a tourniquet above the wound, high on the thigh, and we were able to get the bleeding controlled. As far as GCS score, patient opens his eyes spontaneously, is oriented to person, time, place, and events, and he's able to obey commands. Smiley guy shook your hand when you offered it. GCS is 15, so none of that is a concern for us. So what are we going to do? The patient's low-grade fever is suggestive both of pain and potentially of an infection. And if we ask the patient if he's had a fever or chills recently, he'll say, "Yeah, I've been dealing with something. We know that there's a problem. I've had pus coming out of my knee for a little while. Doctors put me on oral antibiotics, but they just don't seem to be doing it for me." Now that we have a much more severe open wound, this patient is probably going to need IV antibiotics to go ahead and fight whatever infection was already present, plus whatever he's just gained from having such a large open wound. We're going to want to consider some type of sterile gauze or dressing for this patient. Not necessarily control bleeding, because if we controlled bleeding with that tourniquet, then that's no longer our major concern. But our concern is keeping that area clean and free of other types of things that could cause more infectious material to get into that wound. So clean it up, cover it up. I would certainly consider transporting to a trauma center, mainly because this is what I would at least consider a major extremity wound with potential vascular damage, which is a part of the TTA requirements for regions. I have noted that some patients who have had previous surgery want to go back to whatever place that they had had the surgery originally. It may behoove you to mention to the patient that a trauma center is very capable of providing surgery to the patient as well as pulling all of his or her old records. So the decision to just go back to a local hospital where I had had the original non-emergent surgery done makes a lot of sense to me from the patient perspective, but we have to help them to understand that there's a difference between a surgery they elected to do and an emergent surgery that may be necessitated due to the current circumstances. All right, next patient, guys. Pregnant female, as opposed to a pregnant male, I guess, has fallen. 30-year-old female lying on the floor. Family surrounded her with some blankets after she fell. Family states, "We were too afraid to move her. We didn't know what was going to happen. We didn't want to risk the baby." Patient's alert and oriented to person, place, time, and event. She's complaining of specifically abdominal pain. The house looks very clean. It's orderly. It's obviously well taken care of. On your assessment, you find patient is breathing roughly 16 times a minute. Airway is open and manageable. Skin is slightly cool to the touch. Mel has a note in here, would you consider oxygen? Here's my thought on oxygen. If I have a pregnant patient who shows signs of tachycardia or who shows signs of a lower SpO2, I'm going to give quite a bit of oxygen. Even if the patient isn't concerned, isn't having difficulty breathing, if she's tachycardic and there's no reason to be tachycardic, it could be that the baby is struggling to get enough oxygenated blood. So I'm going to try and increase oxygen to mom because that'll increase oxygen to baby. So I would consider a couple of extra things while working with pregnant patients. If mom isn't showing signs of deoxygenation, but patient's vitals suggest that she's in some form of distress, it might be baby that's in distress, and I might give a little bit of the O's just to help with that. As you continue your assessment, you find that has a GCS of 15. She opens her eyes spontaneously. She's oriented to person, time, place, event as mentioned, and she's capable of obeying commands. She has 7 out of 10 abdominal pain. She is 30 weeks gestation. So we're over that 20 weeks, so she's in our special consideration population. And she says pain kind of comes and goes. It's pretty crampy, and it shows up about every 3 to 4 minutes. And when you press on her back, she says, "Oh man, it really hurts back there too." And we're not really sure if she fell onto her side, her belly, or her back. She says she slipped on the stairs and she feels like she kind of spun head over heels, so she's not sure what she did or didn't hit. So for this patient at 30 weeks gestation, if I've ruled out that there is injury to the spine itself, so no pinpoint tenderness on the spine, no paresthesias or loss of sensation in any of the limbs, and no difficulty with the patient's C-spine either, I would probably transport this patient on her side. At 30 weeks gestation, there's the chance of putting her in a supine position could lower her blood pressure, which is something I would want to avoid. So whatever is going to be most comfortable for mom is going to be appropriate. We already talked about consideration for oxygen. Since patients' vitals are all looking pretty good, right? Blood pressure 140 over 90, pulse at 92, respirators at 16. Again, GCS was at 15. I would say this patient you could consider an IV. She's having intermittent abdominal pain every 3 to 4 minutes. Even if you do an ALS intercept, which I would suggest just in case things go awry, but it's unlikely your medic is going to give any narcotics because this is pushing on the third trimester, and most narcotics in the third trimester can negatively affect baby. So we would probably have to call in medical control for their opinion on what we could do to help if this pain was considered to be severe. Other than that, consider transporting to a trauma center. It's best if the trauma center also has some kind of obstetrics or a birthing center that's attached to it. That would be lovely. Not all of them do, obviously. But it'd be nice if mom can get care for both her and baby because she's going to likely have some anxiety over whether or not baby is okay, which is something that on our side of things, we're there to coach mom, to talk to mom, to attempt to, I guess, distract mom from her current concerns as far as that goes. So, things to keep in mind with trauma triage. Is the patient vitally stable? I want to be very clear here. Stable patients, you need at least two sets of vitals to suggest the patient is vitally stable. I can't just base it off my first set of vital signs. I can say patient's vitals are within normal limits on my first assessment, but I need a second set of vitals to compare it to say if they're trending up, down, or remaining stable. Where did my patient get injured? Was it a severe, moderate, or minimal injury or impact? Are there any special considerations? And what is the most appropriate facility for where I should transport this patient? It's a lot of stuff to keep in mind. Thank you guys for listening and paying attention as long as you did. I hope you guys have a good day.